So, Peter, thank you so much for agreeing to present again to us. And this is our second session on research measuring impact as part of the IPALA research webinar series. The session is being recorded, so for those people attending, we hope to put this on the website afterwards. And I'll hand over to you, Peter. Thank you.
Very good. Thank you, Richard. Are you happy for me to start?
Yes, please. Thank you.
Great. And yes, if you can't hear, I can't actually see anyone, but if you could just put something in the chat to Richard, just saying there's a difficulty with the sound or the slides. So this is the second session on research for pediatric academic leaders, and it's covering measuring impact. I'm a paediatrician at the Royal Darwin Hospital, and I'm very grateful for Richard for organising these sessions. So our custom in Australia is to acknowledge the traditional owners of the land where we live and work. I'm in Darwin. I work at the Royal Darwin Hospital, and that is situated on Larrakia land, and I'd like to acknowledge the elders past, present and emerging. So today I'm going to recap the first lecture, introduce the concept of uncertainty, talk briefly about the role of research, and then introduce one way of measuring impact of research, and that's the GRADE approach, give a couple of examples and finish with a list of resources. I'll try and go fairly quickly, but you can go back and listen to the lecture or look at the resources, which are mainly internet sites. So in the first lecture, we covered the importance of a good question using the PICO format. I think it's important that academic leaders in child health are able to use, support and or conduct effective research. And my view is having a good research question means that you will get much more useful information. The PICO format is flexible, can be adapted to most clinical questions. And we're really interested in getting information that can help us make predictions about the groups of people that we can use to then improve health. So this is a quote. It's been attributed to Mark Twain. I'm not sure if he did say it or not. Anyway, the quote runs something like, it ain't what we don't know that gets us into trouble, it's what we think we know that ain't so. And it's really highlighting that clinicians and most people are actually have a bias towards being overconfident, and we're sometimes slow to recognize important uncertainty. Uncertainty can come in two sort of forms. David Sackett used to talk about qualitative differences, and for example, he would say that a qualitative difference would be when you think an intervention works by a worthwhile amount when in fact it doesn't work. There are also smaller differences which he called quantitative, where you might think an intervention reduces an adverse outcome by 15% when really it's more like 10%. So there is some inaccuracy in the estimate, but often these quantitative differences might not change your decision making. However, we do want to be able to make accurate predictions about what's going to happen to people with their conditions, and if they decide to either have further testing or take treatments, and these accurate predictions can be used in shared decision making. Another way of looking at uncertainty is called the Rumsfeld matrix. So Donald Rumsfeld in 2002 made the comment that there were known knowns, known unknowns, but most problematic were the unknown unknowns. And these have also been called black swans by Nicholas Taleb and others. And that was this idea that many hundreds of years ago, the belief was all swans were white, but once a black swan was spotted in Australia, then it was clear that that belief was wrong. But no one had experienced that before, so they didn't even know there was any possibility that they might be wrong. So we want good research information that will allow us to increase our known knowns. But you'll see in the matrix that's a relatively small box, and unfortunately uncertainty is much more common than certainty. Another person who has written a lot about decision making and certainty is Annie Duke, who was an academic, and then she became unwell, and to earn a living when she was sick, she became a poker player and very successful. And then she gave up poker about 10 years ago, and she's now an academic again. And her area of expertise is decision making. She believes that there are only two important things in life: luck and decisions, and she wants to try and help people make better decisions. And she thinks you can do that if you quantify your certainty and imagine that you're going to make a bet about something, and how confident are you that you're making the right bet. Importantly, we often think in black and white terms, but certainties or probabilities of 0% and 100% are problematic. They almost never apply. This person is always thought-provoking and often controversial. This is John Ioannidis. He's a professor of public health and epidemiology at Stanford in the USA, originally from Greece. In 2005, he published a paper in PLOS Medicine called "Why Most Published Research Findings Are False." And it was a theoretical paper, but he was making the point that when we do research, if we're not thinking about the likelihood that a research finding is true before we do the study, we may overinterpret the results. So we may find things that are statistically significant by chance that on further testing can't be replicated. And he pointed out the exception to this rule is often the well-designed randomized trial, where the pretest probability or the probability that the intervention is going to be beneficial might be 50% before you do the trial. So that's why you do the trial. You're not sure whether it's going to work or not work. And yeah, if you want to read more about it, it's actually Why Most Published Research Findings Are False has got its own Wikipedia page. So let's look at some evidence that's used to help decision making. So on the left-hand side of the slide is the Cochrane logo. So the Cochrane collaboration produces systematic reviews of mainly interventions, and the logo was designed in 1991 by Ian Chalmers, and on either side of the purple central line and horizontal lines were two C's, which were meant to stand for the Cochrane collaboration. And then each of the horizontal lines is one of the trials that was done where pregnant women at risk of premature delivery were given antenatal steroids, and the outcome was perinatal death or neonatal death. And Ian Chalmers wanted to highlight that in 1991, if you'd combined all the evidence, you would have seen that steroids were highly likely to be beneficial, but it was many years later until steroids became standard, use of steroids became standard practice. On the right-hand side, that's the updated Cochrane review from 2023, and you can see that perinatal death affected about 13% of women if they got steroids, and a bit more than 2% more than that if they didn't. And this presentation of data is called a forest plot. So the central line is the line of no effect. Each horizontal line is a trial, and in the middle of the trial there's a blob, that's the point estimate, and at the bottom of all the horizontal lines is a diamond, which is the overall estimate of effect combining all of the trials in a meta-analysis. So in the Cochrane reviews, they also have a summary of findings table. This will be too small to read, but this is the summary of findings table, and it's looking at perinatal death. It's in the PICO format, so it's women at risk of preterm birth, setting was hospitals, intervention was corticosteroids, and the comparison group were placebo or no treatments. The relative risk is 0.85, so a relative risk reduction of 15%, and that's converted into an absolute risk difference of 2.3%. Now, next to that, you can see 4 circles with crosses in, and that's the certainty of evidence as assessed using the GRADE approach. So it's high certainty of evidence. So the GRADE approach builds on the 3 key principles of evidence-based medicine. Firstly, that there is a research evidence hierarchy with systematic reviews of randomized trials at the top and observational non-randomized studies at the bottom. The second principle is that research always needs to be synthesized to draw conclusions. And the third principle is an ironic one, that evidence is not enough to make decisions. There are many other factors that patients consider in deciding which healthcare they would like to receive. So the GRADE process is systematic and standardized. It's got 8 steps. It starts with the PICO question and thinking about which clinical outcomes are critical to average populations of patients, and it finishes with recommendations about how to assist individuals with decision making. And this is a 1-slide summary, and again, you won't be able to read it, but it is a really excellent overview of the GRADE approach. So step 1, you formulate your question. Step 2, you decide on which outcomes are either critical, important, or not important. You then, in a systematic review, assess the data and summarize the estimates of effect. And then your next step is an important one, and it's looking at the certainty of the evidence for each outcome. And randomized controlled trials start as high certainty but can be graded down to low or very low certainty. And observational studies start at low certainty but can be graded up to moderate or high certainty. Once you've got your overall certainty of evidence. And again, there are 4 categories: high, moderate, low, and very low. The panel then takes this evidence into consideration along with other factors like the balance between benefits and harms, values and preferences of typical populations, and potential costs and or what some people call opportunity costs. So there's two steps there. There's the systematic review step, reviewing the evidence, and then there's the guideline formulation step, which is coming up with a series of recommendations. In terms of predicting outcomes, there are 2 parts. So there's a probability estimate and a certainty estimate. And the cartoon here, which is used in a lot of the grade approach presentations, has 2 weather forecasters speaking to each other, and one saying, I think there's a 40% probability of rain and a 10% probability that we know what we're talking about. The certainty estimates, generally the high and moderate are regarded as fairly reliable, and the low and very low are less reliable. So high means that you think it's very unlikely that further research is going to change your estimate of effect. Moderate means that your point estimate is probably pretty good, but with more research there'll be more precision around that point estimate. Low means there's a chance that the point estimate may change and the precision will definitely change. And very low means you're completely uncertain. You have no clue really what the impact of the intervention is going to be. So this is the process for grading down and grading up. As I mentioned, randomized trials are regarded as more reliable when you're assessing interventions. So they start initially as high certainty, but if they're indirect, so if the population, intervention, or outcomes are different from the population, intervention, or outcomes you're interested in, then it should be graded down. So, for example, surrogate outcomes would be an example of where indirectness would be a problem. Imprecision is statistically related to the 95% confidence intervals, but other things like risk of bias and inconsistency and publication bias can also affect how confident you are about the precision of your estimate. Risk of bias looks at things like how well is the randomization done, how good is the blinding, how good's the follow-up, was there any selection of outcomes based on the results, or was it all determined before the investigators saw any of the results? Inconsistency really means some of the outcomes are finding one thing and others are finding something else, or where you're looking at several studies in a review. Some of the studies might find a positive effect and others find clearly no effect or potentially a negative effect. And again, publication bias is only something you can consider when there are lots of studies, but we know that studies that find positive effects will be published more quickly than studies that don't, and that they'll also probably more likely to be published. For observational studies, it's possible to move up from an initial grading of low certainty if the effect size is very large, and a large effect would be a relative risk of 0.5 or less, and a very large effect would be a relative risk of 0.2 or less. So that's the same as a 50% relative risk reduction, so a halving of the outcome of interest, or an 80% relative risk reduction, so reducing the outcome you're concerned about by more than 80%. And you might grade up by 1 or 2, depending on how large the effect was. You can also grade up if there's a clear dose response, so exposure to the intervention or the risk factor. The more exposure you get a consistent effect. So the either good or bad outcome increases clearly in line with the increase of the exposure. And the final reason why you might want to increase the level of certainty for an observational study would be if the confounding you're worried about actually could only be making the effect size smaller than it really is. So if you were able to control for all the confounding, the effects would be even bigger than have been described in the studies. So once you've looked at your certainty, you then move on to your recommendation. This is within the guideline phase. Firstly, the guideline groups decide whether they want to recommend for or against the intervention or the action. And then they need to decide whether they want to make a strong recommendation or a conditional or weak recommendation. And they make this decision based on 4 factors. One is the certainty of evidence. So if the evidence is high or moderate certainty, you're more likely to be able to make a strong recommendation. But you might not. Even so, if the balance between benefits and harms, and many interventions have both benefits and harms, if the balance wasn't too persuasive, or if the values and preferences of a typical population would mean that they wouldn't be keen to follow the recommendation, or at least they'd want to think about it. And finally, for the population, there might be a significant opportunity cost in trying to deliver the intervention. So guidelines can only comment about the typical populations, but when you're dealing with an individual, you'll have to make further adaptations to your specific individual. So you'll still look at the guideline, but your individual may have different values and preferences, or there may be different opportunity costs for them than from the rest of the population. So one of the key issues with the GRADE approach is understanding precision. And again, this is a sort of hypothetical forest plot showing different estimates, point estimates with confidence intervals around them, or credible intervals, how likely you think the results are going to be different from the line of no effect. So you might think your recommendation has a overall net benefit, or a likely net benefit, or a possible benefit, or likely no net benefit or harm, or possibly no net benefit or harm, but possibly also there may be benefit or harm. So you can see there's quite a range, and as you get more information, hopefully you get more precision. So initially with research, we're trying to work out what the point estimates are, but over time we become more interested in working out if there's heterogeneity between populations, and trying to make the estimates more precise. It's not straightforward, and everything about the GRADE approach requires some judgment. So, for example, how you think about precision requires judgment about what target you're aiming at. So, simplistically, you might just look at a yes-no approach. So, imagine an example where you think that an intervention that you can take for many years, let's say taking statins every day for 5 years, you might say, yes, you'd be willing to do that if it reduced your risk of death by more than 1%. So a number needed to treat of 100. So 100 people like you would be needed to be treated for 5 years for one person to avoid a myocardial infarction. And you can see in this example, the point estimate looks very positive, a 2% difference, but the confidence intervals crosses your threshold for a small effect. So that's an example of what you might do doing a simple yes-no approach using a risk difference measure of effect. You can also use a relative risk measure of effect, and you can make it more complicated. So you can consider whether you're interested in a small effect threshold, a moderate effect threshold, or a large effect threshold. And you can see that people have proposed that for relative risks less than 0.5, they should be considered large, between 0.5 and 0.7 moderate, 0.7 to 0.9 small, 0.9 to 1 being the line of no effect, being trivial. And on average, most trials of interventions in medicine find relative risks of around about 0.7. So that's not a bad starting point if you're trying to think how big a study should I design. You could say, let's imagine the relative risk of your new intervention was 0.7. So let's move on to a couple of examples. So I talked briefly about Trevor Duke last time. Every year he produces a list of randomized controlled trials that have been conducted in low and middle income countries around the world, and he's just provided us with his list for 2024. They're all published on the PNG Pediatric Society website, and that link is in the IPALA website as well. So this year, most of the studies identified have free online access, so you can click on the link he provides and it will take you to the actual paper. He comments in his summary that the grand convergence of health and medicine between developing and developed countries continues, and that more and more studies are addressing the causal influences on the Sustainable Development Goals. So let's consider a couple of scenarios. In both of them, we're interested in studies that might be relevant to healthcare in Africa. And I was very interested that one of the studies Trevor listed described the assessment of a simple, cheap treatment for a condition known as nodding syndrome. Now, I had never heard of nodding syndrome. It only occurs in a few African countries, but it is a really terrible condition. And if you Google it on the internet, you can see videos produced by the World Health Organization, and there's a lot of interesting information easily available. Anyway, the simple intervention in the trial was associated with reduced hospitalization and death. And so I wanted to do a grade assessment to see how this study might influence guidelines and policies in the future. So this is the trial. It was published in one of the Lancet journals. The population of interest were children aged 8 to 18 years in Uganda who had long-standing nodding syndrome, which is a neurodegenerative condition which eventually leads to incapacity and can lead to death. The intervention they were interested in was doxycycline, 100 milligrams once daily for 6 weeks, and it was compared to a placebo medication. Now, the primary outcome was a surrogate outcome, and it was the presence of antibodies to host neuronal proteins. And the reason for that was their biological hypothesis was that this condition is an abnormal immune response to Onchocerca, the worm that causes onchocerciasis, and Wolbachia, which often lives within the worm. That there was an abnormal host immune response that cross-reacted with the brain and was caused the neurodegenerative condition and often associated with seizures. However, they did include some secondary outcomes, and of the secondary outcomes, some were clinical, and one of the most important clinical ones was hospitalization with seizures. The time of outcome was 2 years. So here are the results. 7% of the children out of 120 originally, but they had data on 114, 7% were admitted to hospital with seizures, and in the placebo group it was 18%. So there appears to be a large relative risk reduction, relative risk of 0.39, a number needed to treat of 10. And if we look at GRADE, they've chosen an outcome which is usually considered to be critical. Hospitalization, most people want to avoid. However, the precision, although the confidence intervals are not close to crossing 1, it was a small study, and because it's small, there's much more likelihood that the results might have occurred by chance. And so they look at the optimal information size, and this study is much, much smaller than you would need to be confident that you have been able to identify a true benefit. It's still possible, but you need to downgrade by at least 1 level, and some people would say you could downgrade by 2 levels. The study was extremely well done. There's no problems with risk of bias. However, the results were consistent in that there was no difference in the primary outcome, and so their biological hypothesis was not supported. There was no difference in number of children who stopped having seizures, or the number of seizures they had, or their clinical condition overall. They did report consistency with an estimate of death, but they made an error with the statistics. There were 13 deaths due to epilepsy, 9 in the placebo group and 4 in the treatment group, and in the paper it said that this was statistically significant, but that finding of 4 versus 9 can quite easily happen by chance. There are no other studies of any interventions at all for this condition, so it's not possible to make any comments about publication bias. So overall, the certainty of evidence is low. You wouldn't end up making a strong recommendation for the intervention, but interestingly, I'm sure lots of families would be keen to try it because this is a devastating condition. We can't exclude the possibility of benefit, so this might be an example of a treatment that is not strongly supported by guidelines, but still people are very interested in trying it. So let's look at another example. This is a much larger study. So this year we've seen the publication of a randomized trial of a new malaria vaccine. We know that malaria is one of the most important child health conditions globally, and it's responsible for a huge number of potentially preventable deaths. So let's look at this one and use the GRADE approach to consider the evidence. So this was a safety and efficacy study of the R21 malaria vaccine, and it was published in the Lancet a few months ago. The population were children aged 5 to 36 months in 4 African countries. There were 2 countries in West Africa and 2 countries in East Africa. The 4 countries contributed 5 regions. 2 of the regions had high rates of seasonal malaria, and 3 of the sites had lower rates of malaria but occurring all year round. In all these populations, there was a high use of insecticide impregnated bed nets, and in the seasonal areas there was use of some malaria prophylaxis. The intervention was the R21 vaccine, and that was given as 3 doses 4 weeks apart, and then there was a booster 12 months later. The comparison vaccine was the rabies vaccine, and the primary outcome was a clinical malaria diagnosis, which was defined as fever plus a positive malaria film. The primary outcome was measured 12 months after the last primary series vaccine. So if they got all the vaccines on schedule, about 14 months after being randomized, and the RCT is ongoing. So we'll see some more longer term results coming out in the future. And we'll get a sense of how important the booster dose is as well. So here are the results. Clinical malaria in the first 12 months after completing the primary series. 3,000 young children in the vaccine group, 15% of them had clinical malaria. It was randomized 2 to 1, so there were about half as many children in the control vaccine group, and 41% of them had clinical malaria. Again, a large relative risk reduction of 73%, and a very large absolute risk difference, with a small number of children needing to be vaccinated to prevent 1 episode of clinical malaria. If we look at the 5 components of the certainty grading system, we'll see that in this study there is no reason to grade down at all. So we end up with a certainty of evidence of high. There's only one other small study which had consistent results, and there are studies of other malaria vaccines, but this vaccine looks a little bit better than those vaccines, and it can also be produced in much higher volumes. So this may be a very important intervention in future years. One thing I will say is that clinical malaria was not severe malaria, so most of the children did not get admitted to hospital when they had their fever and diagnosis of malaria. So there will be a lot of interest on the critical outcomes of hospitalization and death. So in summary, the GRADE approach offers a standardized approach for the assessments of likely impact of healthcare interventions. It uses the PICO format for questions and systematic reviews. It helps you describe the size of the effect, the impact, and the certainty of the evidence, which can then be used to help develop guidelines. The recommendation approach within the guidelines can use either a strong or a conditional recommendation. for the average population, and the intention is that the evidence is used to inform decision making. So they have an evidence to decision framework that they recommend. So we've covered the question, how to assess impact. The next webinar is going to address how do we know what is important, and it will be looking at the global burden of disease data. So I'm just going to finish with a few comments and let you know about some really excellent resources. So the first thing is prediction is difficult, and you know, there are millions of researchers doing work all around the world, and it's very hard to know which research is going to have most impact. So this is a photo from University of Pennsylvania. They got into trouble for this photo because it's got the two Nobel Prize winners from last year. And on the right is Katie Carrico, who was a biochemist, and on the left is Drew Wiseman, who's an immunologist. So Drew Wiseman was a staff member at the University of Pennsylvania, but Katie actually wasn't. And in fact, in 1995, she'd been working for a few years at University of Pennsylvania, and she was very interested in messenger RNA. And she was told that her research wasn't of sufficient standard for her to remain a staff member unless she was willing to take a demotion and a pay cut and not be on what they call the tenure track. She did this. She had a friend in a neurosurgery lab, and she was able to work in his lab. She continued to work independently initially on messenger RNA and then with Drew Wiseman and others, but she was basically doing all the work on her own. In 2005, she published an incredibly important paper where she demonstrated how you could change messenger RNA so it wasn't immediately destroyed by the immune response, and so it had the potential to be used for things like vaccines in the future. That paper, which she published with Drew Wiseman, was the reason why they were awarded the Nobel Prize. And in fact, she went back to the University of Pennsylvania a few years later and tried to have her be reinstated on the tenure track program, and they said that her research wasn't of sufficient quality. So she ended up leaving the university and joining a biotech company that was very involved in developing the COVID-19 vaccines. It's very hard. The GRADE approach gives you some idea about how to assess impact, but you never know which research groups are really going to have an enormous impact on our future health. So here's some resources. Again, the McMaster University, where Holger Schunemann works, they have a whole centre set up. There are now GRADE centres all over the world. There's one in Adelaide. I think there might be another one in Sydney in Australia. Oh, no, in Melbourne in Australia. So there's 2 in Australia, but I think there's 17 around the world. About 100 different organisations, including the World Health Organization, the Cochrane Collaboration, NICE guidelines in the UK, the American College of Association of Physicians, have all adopted the GRADE approach for their guidelines. You can here's an example. The World Health Organization has got a set of webinars on how to develop guidelines using GRADE, and there's an enormous number of resources available. The GRADE Working Group has another, it's an international group, they've got another site with lots of webinars and lots of good lectures that are freely available. This is a site just focused on GRADE, but available through the Cochrane Library, and it's got every paper ever written about the GRADE approach and guidelines using GRADE, and lots of other resources there that you can click on. The GRADE Handbook gives you a lot of detail about all the different steps and the evidence for why certain things are important. This is the most recent of the GRADE guidance. So there are now 35 papers on different aspects of assessing impact that have been published in the Journal of Clinical Epidemiology. There was an earlier series done in the BMJ. These are world-class researchers providing really excellent guidance on very sophisticated and complex problems that people face when they're trying to assess evidence and convert evidence into guidelines. And this is an area that I'm interested in. There's a series of 4 papers about the importance of equity in the production of guidelines, and some things that are recommended are likely to increase or decrease health equity. So if you want to know what's new in this area, next week is the Global Evidence Summit. Hasn't been on for a few years, but there will be groups from all over the world who are interested in how you summarize and use evidence. You can go onto the website and see the program. It looks enormous. Things that are obviously topical this year include equity. There's lots of sessions on health equity, climate change, and then generative AI. And that's going to be the thing that will completely change the landscape of how people use and synthesize research in coming years. So I'll stop there and I'll ask Richard if we can turn off the recording, and I've gone a bit over, but there's a few minutes if people have any questions. So